months, I use a different device and brands, and at the end, I give it to them and I say, I don't like it. Okay? When I tried the Tesla chair, I feel the difference. And this is a toast to the first Tesla chair in Costa Rica that I bought in July 2021. And for the good results that we had in the clinic started to grow, and I bought the second one. I bought the second one in December 10, 2021, 5 months later, and the results with the patients was really, really good. So we see different results with the patients. And yes, I have 3 Tesla chairs. Wow. And this is the third one that I bought in September 2022. This is part of my team in Costa Rica. And yes, we have a lot of experience with using the Tesla chair. We try to do different tests with the patients, testing the chair, but using the ultrasound also. That is very important for us. This is a video. Good results that we had with the Tesla chair, I opened in the second clinic, so it's for that I bought the third chair, and they came to change our results in therapy. In the past, we maybe do the therapies like 5 months with a patient or something like that, but it's very tiring for the patient and for us too. But now we do like 12 sessions with the patients, 12, 16 sessions maybe, and it's totally different. Of course, we use different therapies. We do like a mix with radio frequency, FMS, and some exercise, different method that we have now. But we see one different thing with a Tesla chair in the result of the patient. And it's in the close of the bladder neck, okay? In these years, we have done different tests on urinary incontinence for the opening bladder neck. There are some statistics in my clinic. We have 350 patients per week. So this is a possibility for us for doing different testing with the patients. And it's good for us to see the before and after. And the frequency that we work with a patient is 2 times a week. And the symptoms and the recovery of the patient is like 8 or 12 sessions. They feel totally different, and they have the recovery of the symptom. One thing is the symptom, and other thing is the pathology. We can have a patient with a pathology, but we can have a really good reaction with the patient in the recovery, putting out the symptom. Now I want to show you a vision of the physical therapy in the functionality of the pelvic on the bladder neck. There is a lot of classification of stress incontinence. We have different types or different levels. And all the time when we talk about the type 1 or the type 2A, we talk about the urethral hypermobility. And there is some doctors today that they say there is operation or they need our surgery. But later I'm going to show you some results with the ultrasound that we can help the patients with type 1 and type 2A. Well, okay, this is the bladder, okay? This is the bladder, this is the sphincter, involuntary sphincter, and this is the bladder neck, okay? And this is the voluntary sphincter. So if everybody feels a contraction, can everybody sit well now? Let's go I need everybody feels the bones of the ischial bones. Everybody knows ischios, no?
So please sit up, okay, and you can feel the bones with our sitting. Okay.
Now you can feel the bones in this part.
Yes.
Okay, you need to sit all the time like that in these bones. Okay. Now everybody close the eyes, please. I imagine that you're going to cut the ring or try to do a contraction of your pelvic floor. Okay. Try to do at my time. Do a contraction and relax. 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 Try to hold, contraction and hold, hold, hold and relax. There is somebody here that don't feel the contraction. Open the eyes. You can open the eyes. There is somebody that don't feel the contraction. Everybody, okay? Perfect floors. Nice. Well, everybody talks about Kegels or Kegels exercise, but in physical therapy for us is the last option for the patients because there is a lot of indications. We have voluntary muscles. In this moment, you feel it, the voluntary muscles. When we do a contraction, it's a voluntary muscles. But there is a lot of, like 75% of the muscles is involuntary muscles. So when we cough, when we jump, when we do exercise, we need a reaction of the involuntary muscles. So when the patient coughs, we need a reaction of the both sphincters. But if we have a discontrol of these ones, the patient is going to have incontinence, okay? But this one, the bladder neck is involuntary. So if I give to the patient a contraction, just a Kegel or a Kegel to do in home, we don't going to have a good result. It's for that somebody say the physical therapy in pelvic floor doesn't work. Because it's not only the Kegels. We need to think in everything. We need to think in the breathing of the patient. We need to think in the pressure of the abdominus. We need to think in the posture of the patient. For example, there is a lot of patients with this position, like that. And there is like a little belly in this part. All the time with that belly, when the patient have like a little belly in here, there is a lot of pressure to the pelvic floor all the time. So with the past of the years, the patient maybe is going to have incontinence. So we need to think in the posture, in the posture of the patient, we need to think in the breathing of the patient, we need to think in the contraction of the wall of the abdominus. Because if we have a patient with diastasis recti, all the pressure is going down to the pelvic floor. And we're going to have problems with this control of the muscles. So we need to think in everything, not just in the muscle of the pelvic floor, not just in a Kegel or Kegel. Okay? So we need to think in everything. And in the past, we didn't have a result with exercise, a voluntary exercise, in this part, because it's involuntary. We can have a contraction of that muscles. So for me, this is the magic of the Tesla chair that we have now. And I'm going to show you, well, this is some muscles that they work in the urethra. In this part is the bladder neck, and this is a voluntary muscles. When somebody, with a patient do a contraction, we're going to have a contraction in this part. We can have hypermobility for instability of the wall of the vagina, anterior wall of the vagina, or we can have just a weak muscles, okay? And of course, we can have a prolapse, or we can have a problem with the fascia or the ligaments. That if we have a problem with the ligaments, of course, it's necessary a surgery. Now, I want to show you how we use the ultrasound. We use the ultrasound in the perineal part outside. It's not an ultrasound like a gynecologist or urologist. It's totally different. So we put in the perineal part outside, and we have a vision to all the muscles and the urethra, the bladder, the uterus, the rectum. In this part, we have the urethra, the bladder, we have the vagina in here, and we have the rectum in this part. Okay? We put the patient in the bed like that, and we ask the patient some indications. When the patient coughs, we can see the reaction and the reaction of the pelvic floor. We need a good reaction in the patient, because we don't have a good reaction in the muscles and in the sphincters, the patient is going to have some leak, no? We also use the ultrasound with the patient standing. It's a little difficult for the patient, but it's really important for us, because the patient is walking, is with their kids, is doing exercise, doing CrossFit, or whatever they want. So we need to see what happened with the patient standing. And we do the ultrasound, we ask the patient cough and do some tests. And we see what happened. So now, there is a ultrasound test that we use for the urethral hypermobility. There is the pubis. This is the white line that we have is the reference for us, and the dotted line is the urethra. So when the patient coughs, if we have this reaction, that like opening, is a hypermobility of the urethra. So we need to do something for the patient. There is some results. After the results, I'm going to do an example of where the patient coughs. Andre? One? Yes. Okay, this is an example of the bladder. This is the bladder, okay? This is the urethra, okay? This is the uterus, various, and this is the rectum. Okay, so for example, okay, this is the visceral part of the pelvis, right? We have up the abdominal part, Okay? And when the patient cough or do some effort, we're going to have a reaction in the visceral part, right? So I'm going to cough in and we're going to have a reaction of the urethra, okay? All the time we're going to have a lot of pressure that travels to the abdominus, to the pelvic floor, and we need a reaction, a really good reaction of these parts. This is normal, okay? And this is not normal. Okay. That's a lot of pressure in the visceral part, and we need to understand what happened. And we can see this with the ultrasound, a functionality ultrasound. So it's for that we need a good diagnostic for the patient with the ultrasound, okay? A functionality ultrasound. Gracias. Thank you so much. Now I'm going to show you some results. This is the first case. It's a female, 38 years, postpartum, just one pregnancy and 12 shared sessions. I'm trying to explain a little bit in this moment the ultrasound, okay? In this part, we're going to see the bladder. In this part is the urethra. This is the vagina, and this is the rectum part, okay? So the patient is coughing in this moment, and we need to see this part. It's like opening, and this is the bladder, the neck bladder. I put it again. Everybody see it? Yeah. Yes?
Okay.
We can see here, she had incontinence, and this is the real cause of what happened, or why she had incontinence. And this is after 12 sessions. She had more stability in the anterior part, and the opening bladder neck doesn't exist. I'm going to put both together. There is opening bladder neck, and it's totally closed. And it's a really good reaction and protection in the patient. And this is just 12 sessions of the share. When we have a patient with the opening bladder neck, we use only the sledger. We don't use nothing more. If the patient needs other things, we do 12 sessions and we do a radio frequency or other things later. The second case is a patient, as a female, 48 years, stress incontinence, 3 C-sections, and we do 8 shared sessions. This is a patient, I think it's a patient, yes, from Panama. The same thing, we can see here the opening bladder neck. We can see here also hypermobility of the wall, a posterior wall of the vagina. And this is the beginning for us, the rectum cell. And we can see here the difference with the patient. It's totally closed. This is amazing. This result is amazing. We need to work with her more radio frequency for give her more stability in the rectum part, but we can see here both together. It's totally closed. And she had more stability and a good reaction to the pelvic floor. This is the third case, female, 37 years, stress incontinence in sport, 2 vaginal partum, 12 shared sessions. opening bladder neck. And this is the result. I put together. It's amazing the difference. The fourth case is a male, 58 years, stress incontinent post-prostatectomy. There is someone yesterday that asked that we can use the Tesla chair post-cancer. And yes, we use it. It's really important for the patients. And all the time I ask to the doctor, of course, to the oncologist, that it's possible to use, and if it's okay, we use it. Okay? This is more difficult to see. This is a problem in a voluntary mouth, in a voluntary sphincter in this part. When he coughs, we see the opening part. This is the bladder. And this is, he have more stability, but he needs more sessions. He uses like 5 pads, and at the end, he used like 1 pad per day. And that's good for him, because he have a lot of damage in all the tissues. Well, for us, the good part that we have with this strap is for we can use the posterior part. We need to think in the patient with everything. So we use the multi-urge incontinence because we have neuromodulation settings. So for us, the conduction of the nerve is the queen of the body. If we don't have a really good conduction of the nerve, we're not going to have a really good reaction in the muscles. So we need to use some activations of the nerves. The first session, the first or second session, just neuromodulation, and later we work the muscles and the contraction with multi-stress incontinence and multi-stretching. And this is how we work. And this is the testimony of the patient.
I had urinary incontinence and used the chair as treatment for depressions. After that, my symptoms went away and now I'm pursuing treatment with sports and living myself. I'm really happy with the results.
This is a patient that is